circulating to things like influenza and pertussis. It's an active transport system that involves something called the neonatal FC receptor. And that same receptor is important in actually maintaining circulating maternal antibodies in a newborn for up to 6 months, the first 6 months of life. We also know that there is some element of immune protection from breast milk, but really the bulk and the majority of immune protection in a newborn comes from that transplacental IgG. So breast milk contains IgA, which is our secretory antibody, and IgA does not provide systemic protection. Only that transplacental IgG provides systemic protection. There have been studies that show that breastfeeding is associated with a lower risk of acute RSV or lower respiratory tract infection. And where it can become a little tricky is what you're actually attributing the credit for protecting the baby to. So what I mean by that is if I'm a mother and I just had a baby and I have IgA in my breast milk, well, I also have circulating IgG as well. So is it solely the responsibility of that IgA from breastfeeding versus a kind of collaborative protective process between both secretory IgA from breastfeeding as well as circulating passive IgG? And this is nothing new. The concept of kind of administering something to a mother to help allow for that passive immune protection in a baby. It's the reason why rubella is in MMR. The goal for that is to prevent congenital rubella syndrome. So we immunize against rubella to protect from fetal congenital rubella syndrome. We also have some diseases that are increased in risk towards both the infant, but also there's higher risks during pregnancy as well. Influenza and COVID are examples of infections that can cause greater devastation during pregnancy, because pregnancy is the time where the immune system is somewhat suppressed in order to help grow a healthy term newborn. So we vaccinate with influenza and COVID vaccines during pregnancy to provide protection to both mom and newborn. But pertussis is an RSV vaccine now. The recommendations are really strictly focused on protecting that infant from catching that disease through that passive immune protection. So with that, I'm bringing us up to all the fun stuff that has happened in 2023 with RSV prevention. So there were actually 2 RSV vaccines that were approved in 2023. Both of them are what we call inactivated recombinant vaccines. Both of them focus on the pre-fusion F protein of the RSV virus. Another thing is that both of them have names that are kind of similar. So you've got Arexvy and Abrysvo. I kind of wish somebody had picked a slightly different name, but I am not part of the decision-making. However, the reason why I say that is because only the Pfizer Abrysvo product is what's approved for use during pregnancy. Both Arexvy and Abrysvo are approved for use in adults age 60 and older as a way to prevent and protect them from severe outcomes from RSV infection. Some other things that are important when you're considering maternal vaccination are that Abrysvo, which is the Pfizer product, does not contain an adjuvant. And adjuvants are additives that can be put in some vaccines to boost the immune system's response to it. Where this becomes important when it pertains to maternal vaccination as well as childhood vaccines is that adjuvants have been a focus of attention for people who are not supportive of vaccination. And they say that adjuvants can be dangerous. So things like aluminum salts. So with that, as much attention is paid as possible to provide non-adjuvanted vaccines during pregnancy, as well as to children. It kind of as thimerosal was pulled out of vaccines, adjuvants became the new bad guy in vaccines. But that's important to know, because if someone were to ask, if a pregnant female asks, is this RSV vaccine adjuvanted? The important thing is that no, it is not adjuvanted. And hopefully that will gain some favor and some trust. But Abrezvo is the only product that is approved for use during pregnancy. So in addition, in 2023, a new RSV monoclonal antibody was approved called nirsevimab. The brand name is Beyfortus. It's produced by Sanofi Pasteur. We have had RSV monoclonal antibody for 25 years, palivizumab. So this is a new, longer acting RSV monoclonal antibody that was approved. So all of these things happened very quickly basically from June until September. And so with all of this different information circulating, I thought it's important to focus on RSV prevention for newborns. Another thing that's important when a pediatrician or pediatric clinic is considering the administration of the monoclonal antibody is that I usually use vaccination and immunization interchangeably, but now terminology matters. And vaccination is the administration of a drug that's meant to stimulate active immunity and create immune memory in the person who receives it. Immunization, on the other hand, is now a broader term that is used to describe any drug that provides some form of immune protection, whether it is passive protection or active protection. So the CDC determined that because they have the CDC schedule of childhood immunizations, they decided that nirsevimab is eligible for inclusion in that childhood immunization schedule. So this is the first time that the ACIP, which is the immunization committee under the CDC, has added a non-vaccine to the childhood immunization schedule. This also meant that nirsevimab now fell under Vaccines for Children, or the VFC program. But keep in mind, nirsevimab is not a vaccine. It does not stimulate the immune system. It is passive monoclonal antibody. There is no immune memory. And the passive monoclonal antibody eventually does get broken down by the body, but nirsevimab is longer lasting than palivizumab. So that protection, that passive protection, lasts 5 months. Now, what I have recognized, because palivizumab or Synagis has been around my entire career, is that palivizumab is not under the Vaccines for Children program, and it required prior authorization, and that annually, when I was a general pediatrician, we would wait for the AAP to kind of dictate to us what the diagnostic criteria were for a child to receive palivizumab. And then we identified those children, and we had what we called our Synagis clinic, which was monthly. And those patients had to be able to come on those specific dates to get their monthly injection. And so I feel like a lot of us are very familiar with the fact that RSV monoclonal antibodies are very safe, can be very effective. And now we have a new one that is longer acting, and it's the 2.0 version. And so when patients or parents maybe ask questions or concerns, I want to remind all of you that you all have experience with RSV monoclonals and how safe and effective they are. It's just now you have a longer acting one. Another reason why terminology matters is that nirsevimab, not being a vaccine, so it's not a vaccine, it's an immunization or a drug, but your normal vaccine administration codes don't apply. So it's a therapeutic injection, not a vaccine. So your coding changes. In addition, it does not have a VIS because the V stands for vaccine, and instead it has an IIS, immunization information sheet, that is put out by the CDC. So I'm going to go into some practical considerations and some current clinical situations for this RSV season, because as all of these drugs came out, we also hit a drug shortage, which is slowly starting to resolve, but is still happening. So this is kind of the side-by-side comparison between the new maternal vaccine for RSV during pregnancy and the new monoclonal antibody recommended for all newborns to receive. So for the vaccination must happen between 32 and 36 plus 6 weeks gestation. By day 14 after a woman receives a vaccine, the maternal IgG production is presumed to now reach protective levels. And that is going to be an important number to remember, because if the woman delivers her baby prior to day 14, it cannot be assumed that there was enough time for passive protection to be pushed to the infant. And so therefore that vaccine is not considered protective. Passive maternal IgG has a relatively long half-life in newborns and otherwise healthy term infants. So a term baby born to a vaccinated mother who received that vaccine 14 days or more has passive protection against RSV for about 3 to 6 months, which is wonderful. It's amazing. And again, we rely on that passive protection for things like pertussis and influenza. The monoclonal antibody, again, anti-RSV monoclonal antibody nirsevimab, is longer acting than polivizumab, and the duration of protection for that is 5 months. So current recommendations for maternal RSV vaccination, both ACOG and SMFM, which is the National Organization for Nurse Midwives, recommend Pfizer's RSV vaccine Abrysvo for pregnant patients between 32 and 36 plus 6 weeks gestation as a safe and effective option for preventing severe RSV illness in infants. They also urge clinicians to clearly document the receipt of this vaccination in the medical records. And again, that ties back to that 14-day window. So it's not just enough to know that a woman received it. You want to be able to reliably know what the date was that she received her vaccine, because that will impact decision-making for the infant. So verified receipt and documentation of maternal vaccination is important, because if it's been less than 14 days prior to the delivery of the baby, that baby should be considered eligible for nirsevimab. If it's been 14 days or more and it's an otherwise healthy baby and an unremarkable delivery, there is no need to administer nirsevimab on top of it. It's considered duplicative to do both RSV vaccine and monoclonal antibody in the same otherwise healthy infant when there's been at least 14 days from vaccination to delivery. Another area where this can probably get very, very confusing very quickly is that there's a difference between what the FDA has licensed nirsevimab for versus what the ACIP/CDC have approved. So the FDA has approved nirsevimab for use up to 12 months of age during the first RSV season and up to 24 months of age during the second RSV season for high-risk babies. That's what the FDA decided. And if you were to go to the product page, that's what you will see. However, I want to remind everybody that we really need to follow the CDC guidelines. So the CDC guidelines have approved nirsevimab for infants from newborn up until they are 8 months of age for their first season. It is also approved for 8-month to 19-month-old infants during the second season if they are high risk, which the CDC does define high-risk conditions. Another reason why it's important that you follow the CDC guidelines is that a VFC drug can only be used in accordance with those ACIP guidelines. So if you administer a VFC drug to a baby who is 9 months old and is not high risk, that goes outside of the guidelines for VFC, and it's an error according to their guidelines. In addition, insurance coverage is only required for drugs that follow the childhood immunization schedule or ACIP guidelines. So if you go outside of ACIP guidelines, you run the risk that an insurance company will not cover that drug. So even though it is on guidance for on label for the FDA licensure, you go outside of ACIP CDC guidelines and you may be on the hook for the cost of that drug, which is a significant dollar amount compared to most other immunizations. So here's some more detail specific to what babies would qualify for nirsevimab. Again, infants less than 8 months old, born during or entering their first RSV season, should receive nirsevimab, or it should be offered if any of the following occur. So the mother didn't receive an RSV vaccine, or the RSV vaccine was received less than 14 days prior to delivery, or maternal vaccination status is just not known and you don't have access to any records. You can also consider giving nirsevimab even if maternal vaccine was given 14 days or more prior to delivery. And there is some leeway in terms of clinician decision making, but really what it comes down to is clinical situations where, despite maximizing maternal vaccination, there's either impaired response to vaccines, impaired placental transfer, or that there has been a complete loss of passive antibodies transferred to the baby. So, for example, if mom has an immune deficiency, then she's going to have an impaired response to any vaccine. Women who have HIV infection have impaired transplacental transfer of their antibodies. So in those clinical situations, you would still offer nirsevimab even if the mother is fully vaccinated and it was given within a timely manner. If an infant receives cardiopulmonary bypass or some sort of exchange transfusion, they have lost all of their passive antibodies, not just RSV antibodies. And so because we have nirsevimab, they would be eligible to then receive nirsevimab. And then if you have babies with just substantially increased risk for severe RSV disease, severe congenital lung condition, severe congenital heart condition where they are requiring oxygen and a lot of airway support, then even if the mother was fully vaccinated, meaning it was 14 days or more, there is leeway for clinicians to decide that this baby's risk for severe RSV disease is so high that they would also be eligible during their first RSV season to receive nirsevimab. There are two formulations of this drug, the 50 milligram and the 100 milligram. So another important thing to understand is that the key difference between the 50 and the 100 milligram in terms of eligibility, it is weight-based. So when you have a child coming into your clinic, if they did not receive nirsevimab from the newborn nursery, or if you are working in the newborn nursery and you have a baby who weighs 5 kilos or more, you want to pay attention to that 5 kilo mark because that's where the dosing changes. And these are pre-filled single dose syringes. The cost per syringe is the same, but the important thing is that babies 5 kilos and greater really are more likely to be a little bit older and more likely to require that higher dose for immune protection from nirsevimab. When you look at the second season for RSV protection, this is for babies who are 8 months through 19 months of age. And this probably looks a little bit more like what we're used to with palivizumab guidelines. So babies with chronic lung disease of prematurity, those who require extensive medical support during the first 6 months of that first RSV season, babies with severe immunocompromise, also American Indian and Alaska Native children. And so in this instance, it is 8 to 19-month-olds, and it doesn't matter what their weight is, the dosing is 200 milligrams. Now, remember I said there are only 2 doses that are manufactured, the 50 and the 100. So for babies who qualify, you're actually administering 2 of the 100 milligram doses on the same day. And it is just like if you were giving any other 2 injections on the same day, you want to make sure that there's space in between the injection site, but they're administered on the same day, 200 milligrams. That can become very important when it comes to some of your coding and billing as well. So a little side-by-side comparison, nirsevimab versus palivizumab. Neither one of these monoclonal antibodies interferes with immune responses to childhood vaccines. So if your clinic has nirsevimab and you have a 2-month-old that comes in tomorrow, you can still give them their routine 2-month well baby shots, as well as offering them nirsevimab if they're eligible. A key difference and advantage that nirsevimab has is that first, it has greatly enhanced neutralizing activity compared to palivizumab, and the FC region of the monoclonal antibody has that mutation, a YTE mutation, that significantly enhances the half-life of the drug. More and more monoclonal antibodies that are being manufactured are having that sort of modification. So that way it doesn't last the 30 days like palivizumab lasts, and it lasts at least 5, if not 6 months longer. So more and more you're going to see that modified monoclonal antibodies have this wonderful long half-life. Nirsevimab is on the CDC routine childhood immunization schedule. Palivizumab is not. Again, that's important from an insurance standpoint because during this season where there's shortage, palivizumab still requires prior authorization in order to administer it. If nirsevimab is administered to a baby, there is no indication to also administer palivizumab during the same season. But if you have a baby who is started on palivizumab during the RSV season, because we will have children that happens to because there's a nirsevimab shortage, and that child received less than 5 doses of palivizumab, then you can administer nirsevimab when it becomes available. And ideally, you want to give it within 30 days from their last palivizumab dose, because palivizumab doesn't have that modified region, so it only lasts for about 30 days. Children who qualify for second season RSV prophylaxis with palivizumab are also going to qualify for second season nirsevimab as well. Again, we all are familiar with those criteria that were put up by the AAP, and they overlap greatly for that second season qualification. The preference, however, is to use nirsevimab, especially when you think about the geography and travel time to get to a clinic that can administer palivizumab. So in the perfect situation where we have ample supply of both, you would choose nirsevimab over palivizumab. When there's not ample supply of nirsevimab, you want to prioritize who receives it to maximize distribution, and also considering things like health equity, access to higher levels of care, and insurance coverage may come into play, because again, palivizumab requires prior authorization. It's not an easy situation, but luckily the state of Hawaii has kind of a small team that can help provide some specific guidance along the way. Another thing to understand, so I've spent a lot of time talking about nirsevimab and how wonderful the monoclonal antibody is. I'm going to go over a little bit of the data that led to the support for both Abrysvo, the RSV vaccine, as well as nirsevimab. But I want to say up front that there has not been a head-to-head study comparing maternal RSV vaccination to nirsevimab. The studies were done in silos, and therefore you can't compare apples to oranges. And the reason why I mentioned that is because until that head-to-head study does occur, the endpoints were slightly different, how they viewed and the windows of study were slightly different. And so RSV vaccination is still very effective. And so I don't want people to feel that if the child can't qualify to receive or can't get nirsevimab because of a drug shortage, that you just give up and don't try anything. Maternal RSV vaccination is still a wonderful option. Also, the RSV vaccine studies in pregnancy, the original windows of administration started at 24 weeks of pregnancy. I'm going to go over the safety signal that came from that study that changed the administration window recommendations, but you'll notice that the start for maternal immunization is at 32 weeks, but yet the study data is looking at 24 weeks. But I'll explain that in a second. So first, I'm going to talk about effectiveness of nirsevimab. And this is looking at a variety of different endpoints. So medically attended RSV, lower respiratory tract infection, just means that medical care was sought in a baby who happens to be tested and has RSV. And really where the impact of this monoclonal antibody sparkles and shines is when you look at babies who are admitted to the hospital with lower respiratory tract infection, where the efficacy of this drug is about 80%. And then it goes up to 90% when you look at babies who are admitted to the ICU with severe RSV infection. During the study windows, there were actually no deaths due to RSV that were recorded, but overall, this monoclonal antibody has shown that it really is very effective. And again, we all have experience with palivizumab, so we also know that monoclonal antibodies in infants is also very safe. The maternal RSV vaccination outcomes, again, it wasn't exactly the same and it wasn't a head-to-head study. They looked in terms of their definition of medically attended and severe lower respiratory tract infection from RSV were a little bit different. And the windows that they observed, they looked in windows, so 0 to 90 days after birth, 0 to 120 days after birth, et cetera, up until 0 to 180 days after birth. But just medically attended RSV lower respiratory tract infection during the first 120 days after birth, it is 57%, which is still really great, considering the fact that this is also the highest risk window for even an otherwise healthy term baby to have a need for a doctor's appointment, urgent care, or an emergency room visit for RSV infection. But where I start to feel very impressed is the vaccine efficacy when you're looking at severe medically attended RSV associated respiratory tract infections. So during the first 3 months after birth, it's 81.9% effective, and it maintains more than 70% efficacy during the first 150 days after birth. And then it does start to decline down to 69% at 180 days after birth. But it just goes to show that maternal passive antibody is still incredibly effective when it comes to helping an infant, protecting them from community-acquired infections that we would not otherwise be able to actually vaccinate them to at such an early age. Now, the safety concern that led to a change in the administration window may come up as a question, either from parents or even some of your friends, or pretty much anyone who is pregnant or planning to be pregnant. They may reach out to you and just kind of ask your thoughts on it. So while they were looking at the cohorts that during the phase 3 trial that were receiving the Pfizer vaccine, what they found was for women who received the vaccine, there was a statistically significant increase in the rate of preterm deliveries. Now, most of them happened more than 30 days after they received the vaccine, but it still did generate attention. And across all of the data, the imbalance in preterm deliveries was actually not statistically significant, but it became significant when they drilled down to specific geographic phase 3 sites. And those sites were all non-US locations. Again, the majority occurred 30 days or more after receipt of vaccination. And one of the challenges is that these trials were underpowered to detect a 20% relative increased risk in preterm deliveries. So it's unclear if there's truly a cause and effect, and that the RSV vaccine is actually causally creating preterm deliveries, because when you only look at US data during the phase 3 cohort, there was no increased risk of preterm delivery. When you look at where it was happening, it is in developing countries, specifically in South Africa. And so more studies are happening to identify why it seemed to be geographically specific that there was this increased preterm delivery risk. However, out of an abundance of caution, the ACIP and CDC, they shifted the administration date to be 32 weeks because all of the data on those preterm births showed the majority were 30 days or more after vaccination. Well, mathematically speaking, if I give a woman at 32 weeks a vaccine, and if she is going to have a causally related preterm delivery, it's probably going to happen more than 4 weeks after. And there's a big difference between a baby born at 32 weeks versus a baby born at 36 or 37 weeks. So instead of the recommended administration window going all the way down to 24 weeks gestation, they moved it to 32 weeks based off of all of the available data on these preterm deliveries that were in the vaccination arm of the studies. Another thing that may come up as a question actually pertains to the safety signals seen in the 60-year and older RSV vaccination groups. So there were separate trials and phase 3 studies that happened. And in the population of 60 and older who were receiving either a Brisvo or a RSV vaccines, there was a slightly increased background rate of neurologic inflammatory events, including Guillain-Barré syndrome. And one of the things that I had to be sure of is when I talk to different audiences, because I'm talking about maternal and also elderly and neurologic events, and GBS means something very different if you're a neurologist that takes care of adults versus if you are in the newborn stage. So I tried to spell it out that there were no inflammatory neurologic events that were reported in the maternal vaccination trials. Something to know is that the rate of Guillain-Barré syndrome in pregnant people is much lower than in older adults. But that may be something that comes up as a question that someone heard about the safety signal for things like Guillain-Barré syndrome, and they're concerned about the safety of receiving the vaccine during pregnancy. The only situation where I would probably have a more risk-benefit discussion is in a patient who has a history of Guillain-Barré syndrome, who is also now pregnant. But for the majority of your patients who have no history of Guillain-Barré syndrome, who are within the age window for pregnancy, their risk for Guillain-Barré syndrome is low anyhow. But the safety concern for maternal vaccination was preterm delivery. The safety signal for 60 and older was neurologic events. So a little bit about the pros and cons for both drugs. I try as hard as I can to not show favoritism for one drug over the other, but some pros about maternal RSV vaccination. So the vaccine is bivalent, and also when you vaccinate somebody, you are creating active immune memory, and you're also creating a polyclonal immune response. So polyclonal immune protection is always going to have an advantage over monoclonal immune protection in that it is more resistant to any kind of viral mutations. Now, the good news is that the RSV virus does not mutate that much, but should there be a mutation in the circulating RSV virus, polyclonal protection is more likely to still maintain benefits to that newborn infant. Another pro is that you're not giving an additional injection to the infant. That can be an important factor for some parents. Another benefit specific to this season is that there is plenty of RSV vaccine available during the current RSV season. The RSV vaccine is less expensive than nirsevimab or palivizumab. You can also give this vaccine concurrently with other vaccines. So if a woman is coming in and she's going to get her flu shot or her pertussis shot, you can administer it at the same time as the RSV vaccine. It's not currently recommended to repeat the dose for subsequent pregnancies. I have specifically asked the CDC this question, and there's ongoing studies, but as of now, if a woman receives the RSV vaccine, has that child, and then has a subsequent pregnancy, currently they don't recommend repeating the vaccine, but I would just keep your ears open because that may change. And another pro of vaccinating the mom is that in addition to her producing IgG antibody, you may also provide some IgA antibody production that could happen and provide some additional layers of protection to that infant if they're going to be breastfed. Again, it was not specifically studied. It's more hypothesized based on what we know about other vaccines and vaccine protection and IgA production. So some cons. It's expensive. So it is less expensive than the RSV monoclonal antibody, but it is still an expensive drug. So for cost comparison, maternal RSV vaccination costs about $295 or $300. Nirsevimab, the cost is about $500. So both are expensive drugs. A pro that I didn't include there, but it's a pro to note, is that if you have a pregnant woman who is under the age of 19, the RSV vaccine is covered under Vaccines for Children. So that's another pro for a young adult who's pregnant. But some other cons about the vaccine: multiple factors can reduce IgG production or placental transfer. So you have to consider the health condition and underlying medical issues of the mom. There's a narrow window for administration. So you only have 4 weeks and 6 days window to administer it. And you require 14 days before it's considered protective in the first place. Another con is that the human body doesn't make a standard or minimum dose of IgG in response to anything. Maternal IgG does wane sooner than the monoclonal antibody begins to wane. And then again, the studies that do show a concern for preterm birth risk, although, like I said, they have not definitively said that there's a causal relationship there. But that's why we have a narrow window for administration. Now let's compare that to pros and cons for Nirsevimab, or the monoclonal antibody. So the pros: protection starts immediately. So they receive the drug and now they have circulating monoclonal antibody, so you don't have to worry about that 14-day window. There's a set dose for the baby, and it's based on their weight, and for second season based on their age. But you don't have to worry about the variation from maternal IgG production. That duration of protection is established to be a minimum of 5 months. So it's got a longer duration of protection. Single administration during the RSV season, and that's a pro compared to Palovizumab, which is monthly. You have no risk to the pregnancy. You can give it concurrently with other recommended vaccines. And again, monoclonal antibodies, they don't create immune stimulation, and they are very safe, and there are rare and very mild side effects. So the primary side effect is a rash, but you're not going to cause a fever or anything because you're not stimulating the immune system with a monoclonal. Cons: it's expensive. Another con for this season is that there have been supply issues for both the 50 milligram dose as well as the 100 milligram dose. And a con is that it does require an additional injection for the infant. So while we have a shortage of Nirsevimab, the CDC issued an advisory refining some of their recommendations during the shortage timeframe. So they want to prioritize the Nirsevimab 100 milligram doses for infants at highest risk for severe disease. And highest risk is any baby under 6 months. And then for the 6 to 8 month olds, those who have underlying conditions that place them at a higher risk for severe disease. And that does include children with neuromuscular conditions that impair their cough reflex and their ability to clear secretions. Another element of the CDC advisory is that you do not use 2 50 milligram doses for a baby who is 5 kilos or greater, or in other words, a baby who should receive a 100 milligram dose. If you don't have a 100 milligram dose available, you don't administer 2 of the 50s. You want to reserve your 50s for the newborns and the very, very young who are under 5 kilos. In addition, if you use 2 of your 50s, you have now used $1,000 worth of drug, and the insurance company may not reimburse you for any of it because you went outside of what the CDC advisory is, that you don't use 2 doses of the 50 milligram. Prenatal care clinicians, so obstetricians and nurse midwives, it's really encouraged that they not only discuss maternal vaccination, but also during the season, they discuss the supply shortage and issues that it presents. So counseling pregnant patients about receiving RSV vaccination to help reduce the volume of infants who qualify for nirsevimab while we do have that shortage. Some other advisory issues for during the shortage is that the CDC is advising suspending use of nirsevimab in children eligible for palivizumab who are 8 to 19 months, and instead giving them palivizumab according to AAP recommendations. A big reason is that an 8 to 19-month-old is using 200 milligrams. So you are administering 2 of a drug that's in supply shortage and potentially missing the opportunity to give 2 babies under 8 months each 100 milligram doses. So there is no shortage of palivizumab. The 8 to 19-month-old babies, it is less than 5% of the population of children. So you would still try to get them the palivizumab while it's plentiful in accordance with AAP guidelines. Now, they do recommend considerations for infants who live in rural locations with challenges to travel to get monthly palivizumab. So it's not an absolute that you don't give them nirsevimab, but you want to be very mindful of who you are giving 200 milligrams of nirsevimab to, who qualifies during that 8 to 19-month second season dosage. Nirsevimab should continue to be offered to American Indian and Native Alaskan children who are not otherwise palivizumab eligible, but are 8 to 19 months old. And then again, prenatal care clinicians really, they are such an important part of this public health messaging. And they also advise prioritizing the use of RSV, which is the other RSV vaccine that is not approved for maternal use, that you prioritize that for your older adults and you reserve Abrezvo for maternal use so that we don't run into a shortage of Abrezvo available for maternal use. Again, when documenting in the EHR, make sure you choose the correct vaccine because there will be 2 options, RSV and Abrezvo, and depending on your EHR system, they may not say RSV or Abrezvo, it may say RSV pre-F fusion protein, but RSV is adjuvanted. And I've noticed within EPIC, that's the key language. So the non-adjuvanted one is the one for maternal use. So making sure that you're documenting the right one. In terms of reporting adverse events, I'm sure a lot of you became or familiar with the vaccine adverse event reporting system, or VAERS. And if nirsevimab, which is not a vaccine, if it is co-administered with routine vaccines and there is any sort of adverse event, you use VAERS. If nirsevimab is given alone and there is an adverse event, you don't submit to VAERS because it's not a vaccine. You actually would submit to MedWatch, which is under the FDA. They are very aware that this is going to be confusing. So if something is accidentally submitted to VAERS that should have been submitted to MedWatch, the CDC and the FDA are going to work to then shift that over. What that could impact is just how soon you get contacted from the FDA about an adverse event. So I just include that there as an FYI. Some important things about coding, because remember, nirsevimab, it's not a vaccine. So there are new codes for the administration. Up here, I have the product codes. I'm sorry, I got a tickle in my throat. So read that while I sip. Thank you. There's new product codes that were approved through the AMA. 90380 is for the 50 milligram dose. 90381 is for the 100 milligram dose. So if you are giving nirsevimab 200 milligrams to a baby in their second season, you would do the 90381 times 2 units. There's also the administration codes for payers. I've included both the payers that did not yet recognize the new codes and then the brand new codes up here. I think last time I checked, most of the Hawaii payers are recognizing the new codes. So we'll focus on what's on the right-hand side. The key difference between the 96381 and 96380 is was there clinician counseling on the day that the baby received nirsevimab? And the counseling done by the RN does not count. So the person who is either the pediatrician or pediatric physician, nurse practitioner, or PA, if they provided counseling on the day of injection, then you are going to use the 96380. If no clinician counseling was provided, then you use the 81. A little bit about Hawaii specific RSV prevention considerations. So Hawaii Department of Health was given the authorization under the CDC to make its own recommendations for RSV vaccination in women and nirsevimab for infants. And so Hawaii Department of Health, because we have a different pattern of seasonality from the mainland, has recommended year-round administration of maternal RSV vaccination and nirsevimab for infants. The Hawaii Department of Health also has released the VFC stock of nirsevimab, and at this time, they are only providing it to VFC enrolled birthing hospitals, and that is just tied to the supply limitations. So those of you who are VFC providers in the ambulatory setting, hopefully as we are starting to come out of this shortage issue, you will be able to receive nirsevimab VFC stock as well. The birthing hospitals on Oahu, and this includes Tripler, may not have enough nirsevimab for all newborns. Again, that makes it very important that you encourage maternal vaccination, that it is documented in the maternal vaccine record. But then also, when you are seeing the patient as an outpatient, whether it's in an urgent care or as their primary care provider, because of the supply issue, you cannot assume that just because the baby delivered in a hospital setting here in Hawaii, that they received nirsevimab. So important to check and verify. And I've been emphasizing, encouraging mothers to bring their discharge paperwork to that first PCP visit, because the ambulatory PCP may not be on the same EHR as the birthing hospitals. Commercial purchase of nirsevimab for non-VFC eligible infants is slowly starting to grow as more product is being produced. But one of the things is that they want to prioritize 50 milligram doses for birthing hospitals for non-VFC eligible babies and reserve the 100 milligram doses for your ambulatory use. And with that, I've got some post-lecture questions, but I want to find out if you, Summer, if you want me to go into the questions or the quiz questions or the chat questions first.
I'll run the poll and you can go over the one question about the shortage, the CDC advisor and the shortage. There was a chat question asking if you can do the 150 dose if the 100 is not available.
Okay, so that's a great question, and the answer is no. And the reason for that is that the 50 milligram dose versus the 100 milligram dose is under FDA licensure weight-based. So a baby will qualify for 50 milligrams based on their weight, and that will disqualify them for the 100 milligrams and vice versa. So if you have a baby who is 5 kilograms or heavier, by FDA licensure, they can't get the 50 milligram dose. And if you go off label, which as physicians and clinicians, we may go off label sometimes, but if you go off label, the insurance company is no longer obligated to pay for that $500 drug. So it is incredibly important that you are following not only the FDA licensure for who qualifies for 50 versus 100, but also the CDC immunization guidelines for who qualifies, because then the insurance company will cover the cost. But for right now, because of the cost of this drug, you have the hands of the clinicians are tied to not go outside of the boundaries of what's defined, because then you are now stuck with a very costly expense that if you do it a couple of times, if you give it to 10 babies, all of a sudden you find yourself on the hook for thousands of dollars that are not reimbursable.
Thank you. Any other questions while you folks complete the post-session questions?
I have a question, which is about health equity and the decisions that were made by the CDC to have different criteria for Alaska Native and American Indian children. We see a lot of those same disparities here with particularly with Pacific Islander patients and Native Hawaiian patients. And I, as somebody who spends a lot of time in that sort of realm professionally, I noticed that in US-based conversations, the way that health inequities shake out here just tend to not be on the radar. So I'm curious if the Hawaii Department of Health or anyone else is either looking at data or thinking about creating criteria for patients here that would kind of mirror those same distinctions that the CDC made.
Yeah, and that was actually a conversation that happened with the Hawaii Department of Health and several different advisors for the RSV committee. So you've got pediatric infectious disease, you have epidemiologists on there, and it was an issue that was discussed and really encouraged that the CDC does go back and look at data on Native Hawaiians and Pacific Islanders and how RSV disproportionately impacts those populations, and consider refining some of the recommendations to be more inclusive of populations that not only historically, but currently are disproportionately affected by diseases like RSV. And then add on the other level for the state of Hawaii, where you've got geography and transportation and timeliness of getting to a children's hospital if that's the level of care that a baby needs. But for this current season, the advisory had to remove that language, recommending Native Alaskans, Native Hawaiians, and we had to stick with what the CDC language was for specific ethnicities. But it definitely was a part of the discussion for consideration.
Thank you. There's actually a great follow-up question from Dr. Campbell in the chat. Can you see it?
Yes. So in the DOH advisory statement, there was a comment about prioritizing Beyfortus or nirsevimab for children outside of Oahu between the ages of 8 to 19 months. This is this guidance saying that any child? No, it is only those who would qualify for a second season of protection. Therefore, 8 to 19 months only pertains to the children who qualify for 8 to 19 month doses. So chronic lung conditions, those who have, congenital heart conditions that, basically anything that would qualify them for palivizumab historically. If they are not living on Oahu and where they do live, there is not easy access to receive the monthly injections of palivizumab, that is where you would prioritize nirsevimab. Otherwise, healthy babies who don't qualify for any RSV monoclonal, they don't get it regardless of where they live.
Great, thank you for clarifying. Looks like for the poll, everybody is almost done. And I think the only question that had a little bit of spread, well, actually the third and fourth questions both had a fair amount of spread. So I wonder if you wanted to really quick review those answers for everybody, and then we can work towards wrapping things up.
Absolutely, I will scroll down. Okay, so hopefully you guys see my screen. So this was the first one, which it sounds like question number 1, most people got right. I think this was question number 2. So if your office clinic has only 50 milligram and you ran out of the hundreds, should you administer 2 of the 50s? False. You should only administer the 100 milligram dose to those who are eligible. According to the CDC advisory during the shortage, which of the following is true? So administration of maternal RSV vaccine is temporarily authorized to be given to infants less than 24 months. No, there is no approved vaccine for infants against RSV. 2, the nirsevimab 50 milligram dose is temporarily authorized for use in infants weighing 5 kilos or more. No, that also has not happened. Number 3, only use nirsevimab for treatment of RSV infection in infants less than 8 months. That is false because none of the monoclonals for RSV are approved for treatment. They are all only for prevention. So that leaves number 4, children 8 to 9 months old who qualify for palivizumab should receive palivizumab instead of nirsevimab this season. That is the statement that is true according to the CDC advisory during the shortage. And I think this is question number 4, true or false? There are no clinical indications to give nirsevimab to a newborn whose mother received RSV vaccine 14 days or more prior to delivery. That is false because there are clinical indications where you would, a newborn would still qualify. And if I slide up, and I will show you what those are. So right here on your screen, you can consider even if maternal vaccination was received, so maternal immune compromising conditions, maternal HIV, infants with cardiopulmonary bypass or any sort of exchange transfusion, so that they had a loss of all of their antibodies, and then infants with substantially increased risk for severe RSV disease. So even if mom got vaccinated and it was 14 days or more, there are some specific clinical conditions where you would still want to administer nirsevimab to the infant.
Great, thank you. It is a couple minutes after 1, so I think we're going to go ahead and wrap up. Say thank you so much to Dr. Mbuthia for a really clear and informative and practical presentation that I think we'll all go back and put to very good use. And just a reminder to folks that we're on this new iEcho platform. There's a PDF of some important material that you're welcome to download from there. And we are very grateful for all of this education. Quick plug for next time, we took a break from our pediatric mental health care series to do this important and timely update, but we will be back to it next time. And we're going to be talking about infant mental health with Erin Larcedo on the 17th. And all of you are welcome. Please spread the word to sign up for the new system if you haven't already, or if your friends haven't already. Obviously, you all have. Have a wonderful day. Happy New Year.
Happy New Year. Thanks, everyone.
Bye.
Bye.